The question, and actually, there is some more data that came out of BC. Just looking at Canadian data, I didn't put it up on a slide, but there was some great work done by Stephen Chi out in BC looking at this question, and he found very similar numbers as well. Because BC has a registry that everything goes through the cancer centers. You can take a look at how patients are getting their prescriptions filled, and it was the same number. It was less than 50% of patients were adherent for adjuvant treatment over the 5-year period. So the question comes, well, why do you think women are non-adherent? So, and this is a question that's not really fully answered, but we're going to take a look at some of the research findings and try and at least partially answer it. Can we advance? Okay, I can't see the next slide. Okay, there we go. Okay, so I'm not going to read all of these, but there are clearly many factors, and this is sort of borne out in several papers that we looked at when we put this presentation together. There are certainly several different types of factors that influence patient adherence, and some of these are treatment related. So we know that patients who, for example, are on oral versus IV, we don't have issues with adherence for IV patients. Things like length of treatment, how much treatment costs, how many drugs the patient is on, all affect compliance. Next slide, please. There are certainly patient-related factors as well. We know, obviously, that cognitively impaired patients don't do as well in terms of taking their medication. Age is a factor, comorbidities, gender, lack of knowledge about the treatment, and lack of knowledge really is actually one of the things that we're going to kind of harp on in this presentation, and the disruption to the patient's routine. There are some environment-related factors as well. Things like social attitudes or patient finances, their attitude towards the treatment, and location of provision, social rank of illness, things like this also play in. And then next slide. Finally, physician or healthcare team related. That should be one point. Following accepted treatment guidelines, the relationship between the doctor and patient, or the patient and the other healthcare members, is important. Aftercare management, and I think that's a really important thing to bring up as well, because I think that's something that we can have a major impact on, and we'll talk about that a little bit later. And provision of information to the patient that is useful to them. So it seems like a truism, but certainly negative or neutral beliefs about value of medication and is associated with discontinuation of treatment. And it seems obvious, but the thing is, that's our job to work towards making sure that patients have a positive belief about the value of the treatment that they're receiving. There's also confusion among patients about how treatments work. So hormonal, anti-hormonal, all these terms that patients may not be familiar with. And patients may not understand the importance of staying on treatment for 5 years, and we'll touch on this a little bit later on. But it's true as well, and I'm sure we're all aware of this, that people with chronic conditions typically don't do well in terms of taking their medication compared to patients who have acute conditions. And we tend to see this dramatic decrease in adherence, especially after the first 6 months of taking a drug. So is there a greater understanding needed? Well, let's look at some quotes from women who were non-adherent. I feel that I took it for more than 3 years. I feel it must have done its job. After menopause, I felt my body would take the estrogen away without having to take any medication. These are quotes from actual patients. And I was thinking, you've already been taking the medication for 2 years and everything is fine. The doctors say everything's fine. I didn't see why I couldn't eventually stop taking the medicine. So that speaks to, I think, us, an increased need. We try and educate our patients, and we do the best we can, but maybe we need to look at doing a better job of it. Now, side effects, of course, also play into this, and side effects can be a big reason why patients don't take their medication. And a lot of this can sometimes be due to patients having unpleasant surprises with side effects and having side effects that they weren't told about in advance. This slide should be not news to anyone. There are various side effects that are related to hormonal breast cancer therapy. And we're going to go through some of these and just talk about management strategies, because I think it's really important to make sure that these patients are managing their side effects appropriately, because that is going to improve adherence rates. So hot flashes is the first one, and I really like this cartoon because in the right panel where all the men are sitting there with their coats on and their hats and drinking their steaming mugs of coffee. Oh, wow, the temperature's turned down. Hot flashes certainly are a problem with these medications. So if we could go to the next slide, please. They're more prevalent with tamoxifen than they are with AIs, but they certainly can occur with any of these medications. And there's a greater increase in hot flashes in premenopausal women that are taking tamoxifen, for example, than in the perimenopausal or postmenopausal women who take these medications. So in terms of management, certainly they can be troublesome. It's helpful to inform the patient that they may abate over time. Some medications that have been used to treat hot flashes include venlafaxine or clonidine, and the doses shown there. They can be considered. I'm sure most of us are probably aware of this is at least with tamoxifen, not with the AIs, but with paroxetine, you do have a drug interaction with tamoxifen, and it's wise to avoid it. And in fact, that's probably the reason why paroxetine worked for hot flashes with tamoxifen, was because of the CYP2D6 interaction, which reduced the effectiveness of the tamoxifen. So arthralgia is another one that we tend to see in a lot of our patients. 25 to 35% are the numbers that are sort of quoted in the trials. And certainly we've been involved in several trials where patients have taken AIs, and it seemed like a lot of them would come back complaining of this. In terms of a strict definition for arthralgia, it's sort of defined as pain or stiffness in one or more joints. And in some assessments, it's led to discontinuation of treatment in up to 20% of patients. And just some data from the ATAC trial. Most of the arthralgia in ATAC was described as a generalized pain in the joints. In reports from the patients who did experience the arthralgia, almost half were sort of described as an exacerbation of a pre-existing condition, which was kind of interesting. But it's worth noting that a lot of these events did resolve within the first 6 months of treatment following the onset. And 75% within 18 months. So that's something that you can certainly tell your patients, listen, this is likely going to abate over time. In terms of management, this is actually from a really good paper in Current Oncology where they specifically looked at this question. It's obviously a good idea to take a history. You might want to consider a bone scan depending on where the pain is. But to stop the medication if the pain is severe, sometimes patients can benefit from a drug holiday. And actually switching to another AI sometimes works. And we've done this with some of our patients, and it's not evidence-based, but sometimes it will work. As far as symptomatic management is concerned, there's a slide with specific recommendations coming up. But you can certainly consider pharmacologic or non-pharmacologic measures. And if you can achieve that 6 months of therapy where you start to get that decrease in the incidence of arthralgia, you want to try and get that 6 months so that starts to abate. You might want to consider referral to a rheumatologist, and remember to maintain communication about this with the family physician. So in terms of actual specific management strategies, it's always a good idea to try non-pharm measures first. So weight loss, exercise, rest, physiotherapy, OT, and massage can be helpful. But if you have to go to a pharmacological agent, what's recommended is you can start with acetaminophen for mild or moderate pain. If the pain's more severe, you might want to go with a COX-2 inhibitor or possibly naproxen. I don't know a lot of clinicians that would want to give opioids for this, but it is mentioned in this consensus paper. And certainly you can use TCA, things like gabapentin, and as adjuncts to other therapy if the therapy you start with isn't working. Now, we all know as well with aromatase inhibitors that there's an increased risk of skeletal fracture. And this is a population that, as we know, is already high risk for fracture because a lot of these women are going to be, older than 50 years. And so you're looking at a population that at baseline is at a higher risk than the rest of the general population. The ATAC trial did, though, demonstrate that the risk of fracture with anastrozole decreases after the patient finishes their 5 years of therapy in the adjuvant setting. So we know that it's more of a problem when the patient is actually on those AIs than it is after they're finished therapy. So risk factors for fracture, low BMD to start with, baseline, if the patient's had a prior fracture, if they're older, or if they have a family history. These are the four major risk factors. So we really need to make sure that we're recommending supplementation with calcium and vitamin D. I'm sure no one would argue with this. Bisphosphonates could be considered depending on what the patient's baseline BMD is, or if there's a strong family history. Zometa might be preferable. This is controversial. We don't know if this is entirely true yet, but certainly there have been some trials that have been published recently, such as ZOFAST and Azure in the postmenopausal breast cancer patient group, and ABCSG in the premenopausal, where it seems like zoledronic acid might improve outcomes in terms of recurrence. Obviously, we don't know for sure whether that's the case yet, but it might be a reason to choose it. Nausea usually occurs early in treatment. It tends to abate over time and be transient. Certainly, we can talk to patients, and if they're having a problem, we can give them something mild like Gravol to try and mitigate that. Now, effects on lipids are a bit more of a controversial topic. Right now, there are no specific recommendations around lipids with AIs, and the data is conflicting. The ATAC trial initially showed a higher incidence of hypercholesterolemia, but over time there certainly were no, and we have a long follow-up on this trial now. It's 11 or 12 years, and there's no difference in terms of cardiac events. And also, Big 198 seemed to show a higher incidence of hypercholesterolemia and letrozole over tamoxifen. But the only placebo-controlled trial to date that we have comparing two AI showed comparing an AI to placebo showed no difference. So it's been postulated, well, maybe the tamoxifen actually lowers the lipids, and that's why the cholesterol was higher in the group that got the AI. Other adverse effects, fatigue. Certainly exercise programs can help with this, and we certainly refer a lot of our patients to these. We try and tell them that and there's an increasing body of evidence showing that small amounts of exercise, not pushing it too hard, but regular exercise seems to help with fatigue. Vaginal dryness can be a problem in these patients. Replens gel can be recommended for relief. There are some practitioners out there that are using local estrogen products. This is controversial, of course, because you worry a little bit about systemic absorption of estrogen in a patient who's ER positive. Thrombosis is an issue with tamoxifen, and patients who are on tamoxifen should be advised to quit smoking and try and control their weight to reduce the risk of this. And finally, endometrial cancer, again, is with tamoxifen is a risk, and it's about 50% higher than baseline population, which isn't, huge amount, but it is higher. And women who have had previous estrogen replacement therapy, as well as those who are obese, may warrant some closer monitoring for endometrial CA. So I think a good question is, are we sometimes glossing over these adverse effects? Because I know that our physicians have a habit of sometimes referring to AI treatment or tamoxifen treatment as mild, and they are mild, I suppose, if you look at them in the context of comparison with chemotherapy, because we all know that chemotherapy is rough for these patients. It's difficult for them to go through. They have a lot of side effects. But we shouldn't gloss over the side effects that are associated with hormonal therapy just because it's less toxic, so to speak, than chemotherapy. So do women need more awareness? I think we can all agree that they do. More quotes from non-adherent women. My doctor said, there aren't any side effects. I've got lots of patients on it, but then I started to get side effects. So, that's And I've certainly heard our physicians say some similar things. My doctor thought that this AI would be better for me, but he didn't say anything about side effects or nothing. My doctor said, I never told you about the side effects because then people start thinking every little thing is from the AI. And what would I have liked to have known? The side effects they put in the pamphlet.